Okay, hello and good evening to all of you, many of you. I think I recognize a few faces in the audience. So it is my pleasure to be discussing this topic of breast cancer with you this evening in the month of breast cancer, October. So, breast cancer in the United States, what should you know? Well, it's the most common cancer in women after skin cancer. Okay, I have estimates for 2014, which demonstrates about 231,840 new cases. And previewing the 2015 cases, it really has not changed that much compared to 2013. So essentially, I think the 2015 numbers, when they come out in January, will be in this same ballpark. Now, the mortality also really has not changed. About 40,290 deaths occur a year from this disease. So it's very high, and that's why we work diligently within this field to try to decrease the mortality that we see women encountering. It's the second leading cause of cancer death in women, and is the leading cause of death in women between the ages of 35 and 54. And this number becomes very important because when we start to talk about the recommendations given by the U.S. Preventative Task Force, saying that women should start having screening mammograms between the ages of 50 and 74, why are we waiting that long? Why should we miss this key group of women? Okay? So 1 in 8 women will be diagnosed with breast cancer in their lifetime. So it's very high prevalence. Now, if you look at the epidemiology of the results and you compare Caucasian women to African American women, you actually see that although the incidence is higher in Caucasian women, the mortality is much higher in African American women. Why is that? Well, let's look at the stages we have for breast cancer. And we can see that essentially more Caucasian women are diagnosed early on, stage 1. Okay? And we have less as we go through stages 2, 3, and 4. Whereas in African American women, most are being picked up around stage 2, then 3 and 4. So why do we have this gap between the similar gender? Is it because of underlying genetics? Is it because of environmental factors? Are women of African American descent choosing to present later because they think nothing is wrong or they feel as though they're not going to be helped? We don't know. Everything is still in research phase. Okay? So, what are the risk factors for breast cancer? Well, understand that risk factors do not cause breast cancer. They're associated with an increased chance of developing breast cancer. Okay? And the number one risk factor for developing breast cancer is being a woman. And that's something many of us cannot change. Okay? I think some have, but many of us cannot change. Okay? Now, age is also a risk factor. Something some of us cannot hold back the time on also. So as we get older, the risk for developing this disease increases. And you can see when we look at age 30 versus in your 70s and 80s, you go from 1 in 2,000 to about 1 in 13 to 1 in 9. And once again, lifetime risk, 1 out of 8 women will develop this disease. So, what are some of the factors that we can control? And what is it that we cannot control? And you have to all take this with a grain of salt, okay? Because some of the things listed on the National Cancer Institute website and as part of the American Cancer Society website, I don't think you can actually control. Well, alcohol drinking, yes, we can control that. And they've shown that excessive drinking actually leads to promotion of breast cancer in women. Being overweight, well, I guess we can control that to some extent. Never having children. How can we really control this? That all depends on us finding a suitable mate, someone we feel attracted to, decide to procreate with that individual. Having your first child over the age of 30, once again, not much control. You'd want to wait until you find a suitable mate to actually have that child. Hormone replacement. Yes, you can control that because you can speak to your doctor to decide if you would like to be placed on hormone replacement. In 2002, there was a big study that came out that showed that women placed on hormone replacement therapy, although it helped or prevented endometrial cancers, it actually promoted breast cancer. So speak to your doctor, okay? Don't start to take things over the counter without informing your doctor. Birth control pills, very slight. Being exposed to large amounts of radiation. And I stress this, large amounts of radiation, not coming in for your annual screening mammogram. that's not radiation that should prevent you from having this imaging study. Deciding to tell your loved one that we're going to take her home and move to Japan next to the nuclear site that just had a little spill, that's exposure. Going to Chernobyl, that's exposure. Going to Hiroshima, okay, that's big exposure. So what is it that we cannot control? Well, the age at which we develop our menses or menstruation, many of us cannot control that. The age at which you start menopause, once again, cannot control. But what happens is that the wider the gap between when you actually start to menstruate and when you start to go into menopause, that is the amount of estrogen that you're exposed to. So you start to menstruate at 10 and you stop at 50, that's 40 years of estrogen, okay? Versus a woman who starts at 15 and then she goes into menopause at 45. Now, having children is key because when you have a child and then you lactate or you breastfeed, that also decreases your estrogen exposure. So having many children is actually good. So we should all be like the Dugards, right? 19 kids, 1 year breastfeeding, that's like a good 40 years of blockage, right? That's awesome. So, however, you cannot also control the family that you're born into. So if you're born into a family and you guys have a high risk for mutations, such as in the breast cancer mutation gene, the BRCA1, you will develop mutations. Getting older, once again, a first-degree relative with breast cancer, you cannot control. A previous history of a biopsy with atypia, that puts you at a higher risk, okay? 4 to 5 times increased risk. So what is the screening methods recommended for healthy women? Well, self-breast exam, I promote that. I say it's your breast, and you should know your breast better than I do. Even if it's lumpy, bumpy, and it feels like a landmine, know your landmine, okay? Know where things are so that when there is interval change, you can show up to the doctor and say, this bump is here, but this is new, okay? And that helps. When should you initiate your clinical breast exam? Well, between the ages of 30 and 40, you should have it every 3 years. And after the age of 40, it should be annual with your annual mammogram. Mammography, you should start at age 40 and continue every year until 100 when you come into my office and we both blow out that one candle on the cake. Now, okay, if you have a family history for breast cancer, you have to start getting screened 10 years from that individual, that first-degree relative, okay? So let's do a math. Mom got it at age 35. When does a woman have her mammogram? She can have it at 25, 10 years, okay? That is the minimum set by the FDA for a woman to have her screening mammogram initiated. Mom got it at 30. She has to start getting screened at 20, but with ultrasounds. And when she becomes 25, we add on the mammogram, okay? Added to that is the breast MRI that can be done at a very young age also because there's no radiation. So this is the controversy that exists right now within the field of mammography because the recommendations put out by the United States Preventive Task Force in 2009 did not change that much with the revision in 2015. They are still recommending that women start to have their screening mammogram at age 50 and terminate at age 74. They are recommending biannual, twice a year. Therefore, you do the math once again. Every 2 years, between the ages of 50 and 74, 24 years divided by 2, that's 12 mammograms in a woman's lifetime. Okay, who's cutting corners? Okay, the American Cancer Society, Obstetrics and Surgery, ACR, or the American College of Radiology, we all promote annual starting at 40. However, they do say decision to start before age 50 should be made on an individual basis. But how many women know this if they are going to an institution where they're trusting their doctors to recommend the next time to come in for a screening imaging study? Okay? They say no additional benefits for screening beyond age 74. I don't support that at all. I have a lot of women in their 70s and 80s who are vibrant, still living life to the fullest. Why should I cut that short by stopping at 74? Okay? So they also recommend against teaching self-breast exam. Once again, that's not something I follow. Okay? So the American Academy of Family Physicians actually supports the USPSTF recommendations. However, there are physicians within the practice who will divert from this and actually decide to recommend to their patients to have annual mammogram. So once again, you may be under the care of a family practitioner who is saying that you only need to come in every 2 years because he's following this. So you can actually override based on what you feel you should be having done. So why are we screening within the field of mammography? Well, because there's a high prevalence of this disease. So what is prevalence? Prevalence is the number of individuals living with this disease in the population. The incidence is the number of new cases. So we have a lot of women living with this disease. Okay? There are multiple studies that have demonstrated a reduction of 30% or more in breast cancer mortality from having annual screening mammogram. Okay? There's improved outcome by treatment during the asymptomatic period. What is the asymptomatic period? The woman comes in for her screening mammogram and the radiologist, finds the cancer when it's small, 10 millimeters, 14 millimeters. I don't want her to come in with something palpable, huge. There's a higher chance that disease has gone to her axilla, lymph nodes, or gone outside of the body, okay? Or other parts of the body. Ooh, we don't want it to go to outside of the body. Okay, and then there's a significant impact on the public's health, okay? Because it changes the morbidity of individuals in the population. So what is a mammogram? A mammogram is an x-ray of the breast, ladies and gentlemen. That's what it is. You go in and you say, my arm hurts, my chest hurts, I'm coughing. You get an x-ray of your chest. You don't ask about radiation. But once I tell a woman to put her breast on that detector and to have a mammogram, you know, they all ask about the amount of exposure that they're being exposed, the amount of radiation that they're being exposed to. Okay? So you have these numbers here, and I'll just go into them in a little bit by breaking it down for you to simplify it. But the amounts of radiation that you're exposed to by mammography is extremely low when you look at the distance one's travel. So if you travel to Europe and back, that's your radiation exposure to your breast. And I have to be honest with you, I get off the plane, I don't stop at the cockpit to find out about the amount of radiation I got during that flight. I'm running to the carousel to get my bags, right? So if you travel by car, it's like, okay, we're going to go to San Francisco, come back. That's radiation, okay? So 2 quick points and then we'll move on. So think about the radiation dose that a woman gets when she's having her mammogram for her lifetime, say between the ages of 40 and 90. She'll get about 20 to 40 rads. But compare that to a woman who has to have radiation therapy. She's going to get about 5,000. But shouldn't that woman develop reoccurrence earlier than any other woman in the population? Why is it that we have women who are survivors? Okay? It doesn't make sense for women to be so apprehensive about getting radiation dose to the breast. Okay? And just another quick view. This here is essentially a lot of the imaging studies that we do. So you get about 0.7 millisievert of radiation exposure from a mammogram. Okay? You go to a chest x-ray, you take your PA and your lateral or your front and side views, you're going to get about 0.07. So it's about 10 times less than a mammogram. But you go to all the other studies, which are bread and butter within the field of radiology, where people are getting CT of the head, CT of the chest, CT of the abdomen and pelvis. Abdomen is 10 millisieverts, okay? That's about, 100 times, 10 times, depending on which study you're looking at, more than a mammogram. Picture that person who's in the ICU and is getting a chest x-ray every 3-4 hours because they're monitoring him. Why is it that patient, when they come out, do not develop breast cancer? Okay? Take everything with a grain of salt. So quickly, what is the difference between a screening mammogram and a diagnostic mammogram? A screening mammogram, the patient is asymptomatic. She comes in, she says, I have no problem. I may have pain, but it's been there 20 years. That's not new. New pain, last couple of months or weeks, that's going to make the study a diagnostic, okay? The study is not read the same day that a patient has the imaging taken. It's usually done the next day, okay? Some women get very concerned. Oh, I want to have a screening mammogram. Why are you changing my study to a diagnostic? I don't want your money. I'm not changing it to a diagnostic to get more money from you. It's because you're telling me you're feeling a lump. If you're feeling a lump, you're not asymptomatic, okay? If your doctor is feeling a lump, you're not asymptomatic, okay? A diagnostic mammogram, something is seen on the patient's screening mammogram, and we call her back to the facility, okay? And so she's under the supervision of a radiologist who will look at her mammogram, decide if they want to take the patient to ultrasound or not, image the patient further to decide if what they're looking at is something benign or something more concerning. So these are just some of the signs and symptoms, okay? Patient can come in with a lump or thickening in the breast, discharge or bleeding, and the discharge we're concerned about, bloody or clear like water.
So what is the best, test done for women that have implants, being that, it's obscured because of the implant?
No, it's not obscured. So women who have implants do not get 4 views, they get 8 views. We do implant views to make sure the implant is intact and there's no disease formed along the wall of the implant. And we do implant displacement views. At that point, we're able to push the implant aside and see your breast tissue. So it's not limited. However, if a woman has a mastectomy with implant placement, that woman should have ultrasound because we cannot do implant displacement views. And it does not matter because she doesn't have any breast tissue, right? Everything has been removed and implants have been placed. So when she has a reoccurrence, she and her doctor will feel it very quickly on her chest wall, right? Because that's where the disease will grow. It's likely that cells earlier on might have escaped from that mass and lodged there because they're trying to get to the axilla or to the chest wall to invade. But once all that breast tissue has been removed, she doesn't need to have a mammogram. But it still works for women with implants, okay? It's the breast tissue density that will dictate whether a woman should go on to having a screening ultrasound on a separate day or she's fine with a mammogram. And I'll show you why in a second. You're welcome. So quickly, right, bloody or clear like water. If it's green, yellow, blue, black, any other color, I listen to my patients, but I really don't care. The suspicion is very low, okay? Pathology is associated with bloody or clear, okay? If you start to have nipple inversion, we're concerned. There's something there pulling Cooper's ligament in, growing there, okay? You start to have crusting or changes in your areolar or even reddening and thickening of that skin, we're concerned, okay? So when I pull up the mammogram, a woman can have 1 of 4 tissue density. She can have fatty, which is about 10% of women, scattered, 40% of women, heterogeneously dense, or extremely dense. And we put you into that category based on what we see on imaging. 50% of women are non-dense and 50% are dense, okay?
Define the word dense.
The amount of glandular tissue you have in your breast. So if you look at this breast, you're seeing pretty much black or gray. That's your fat. The little white things you're seeing, that's your glandular tissue. So this woman is extremely dense, okay? It's gonna be, I read her mammogram, I get no disruption. I read her mammogram, I could be walking out the door, okay? Because cancer shows up white. So white on black, I have contrast. These 2 images, I have to sit there and make sure I don't see any bulges or subtle distortion of the tissue as I compare her current to her priors, okay? And you're constantly looking to see if there's something that doesn't sit well in the tissue, okay? So I'll just end by talking about a case. When we do a screening mammogram, we're looking for several things: masses, calcifications, or distortion of the tissue. So this is a woman that came in for her annual screening mammogram. She had no problems. She just showed up. The case is being read, and there's a mass seen in the middle third, upper outer quadrant of her right breast. This is a fatty breast. This is what I mean about I can read this from out the door, okay? This is her cancer, okay? I know it's her cancer because I can look and I can see the borders and the margins are very ill-defined. Something is growing there that's very irregular, okay? Now, when I take her to ultrasound, I can have 1 of 4 masses that I see. I can see a fluid-filled mass, which is a cyst, a simple cyst. I don't need to do anything about that. That's a benign finding. Or she can have a solid mass, but this mass is well circumscribed. Likely it's a fibroadenoma, but I have to put that in the context of the patient's age, okay? She's 60s and 70s. I'm going to drop that down low. I might actually recommend a biopsy to prove myself wrong. She's in her teens, 20s, and 30s. That's the most common benign mass, okay? It arises from the stromal and epithelial cells within the breast tissue. And I try to tell patients, think of it as the cousin of fibroids in the uterus. They're benign. This mass here is a complex cystic mass. It has both cystic and solid components, so we would recommend a biopsy of that. This is a solid mass, and you can see how angulated the margin is. I'm going to biopsy this also. But for this patient, you can see here there's a vague hypoechoic mass that's there. I already know this is going to come back positive, okay? So this is the mass. Any solid mass seen within the breast, one that look benign or not. We always image the axilla to look at the lymph nodes, okay? Her lymph nodes were fine here, so we took her to ultrasound for an ultrasound-guided core biopsy, okay? Once we do the biopsy, we'll take tissue, send it in a jar with formalin so the cells are fixed. The pathologist will analyze and tell us what type of cells are growing abnormally. Once we're finished with the biopsy, we leave a tiny little tissue marker, a clip, okay? So this is the biopsy, this is the clip. So the clip is in the mass to show that we have accuracy in our biopsy. So whatever cells this come back as, we will believe what the pathologist tells us, okay? And then this also serves as a guide because by having the clip in the mass, Once the patient meets with a surgeon, if it's discussed and found to be that this patient is a candidate for something called neoadjuvant chemotherapy or chemotherapy before surgery to try to shrink your cancer, if she has a good response and this cancer melts away, how do you find it if you don't leave a clip? You've got to leave the clip, and it serves as a little marker for us. Okay, so for this patient here, she had that place, she met with her surgeons, they decided they're going to take it out. We do something what's called a needle wire localization. She comes in, we put some wires to bracket the cancer because the surgeon knows that the cancer is in your breast, but they don't know how far down to cut. So we help the surgeon with this, and they know exactly when to get to the lesion, and so they can just take out the cancer and surrounding tissue so that they have clear margins. And then they take out that tissue and they send that off to the pathologist. And my last slide. Understand, ladies and gentlemen, there are limitations in mammography, okay? As many as 5 to 15% of breast cancers are not detected mammographically. And that's because, especially in our patients with our dense breasts, okay? The causes are, you can have occult cancer. There's a cancer known as invasive lobular carcinoma. Ooh, that one tries to be very sneaky. It hides with your breast tissue. I call her the female form of the breast cancer. Very salient. The male, he shows up. I'm here, okay? You got to be careful of this one, especially in a woman with dense breasts, okay? Your findings can be obscured by dense breast tissue. It could be technical. The way the breast was positioned, if the tech had a difficult time with the patient, getting her to be in a good position, the tissue might have fallen one way, and when the tissue was opened up, there was the lesion. It could be an error of interpretation, the fault of the radiologist, a cancer miss. It does happen. So a negative mammogram should not deter workup of a clinically suspicious abnormality. If you feel that there's something there, you speak to your doctor. The final exam that you can do is a breast MRI. A breast MRI is a functional study. It looks at blood flow to the breast. Your mammogram and your ultrasound are static or anatomical study. We take a picture in real time, okay? If the MRI is negative, then likely what the woman is feeling is just tissue. If it's positive, then she moves on for further diagnostic workup, okay? That's it. Thank you. I now turn you over to the breast surgeon, Dr. Amy Bremner.